Okay, I think we are gonna make a start. Hello, everyone. It's my pleasure to introduce you to Yolande, who has been working on FTD for many, many years, and I knew her from before on my days in Jamfi. But yeah, it's really good to have you here, and I'm just not gonna delay your start, and we want to hear everything about FTD. Thank you so much.
Thank you very much, Aitana, for inviting me this morning or beginning of afternoon. I've already had a tour through the center, so that was very interesting to hear about all the interesting research that's going on here. Myself, I'm a leader of a group working on young onset dementia with a high interest in frontotemporal dementia located at the Alzheimer's Center of Amsterdam. And today I'm going to talk about the challenges and the pitfalls to make a good diagnosis of FTD, but also to develop biomarkers in the proper way for FTD. These are my disclosures. And I just want to start with a brief movie. I hope it works if I click on this.
En dan straks doen het permanent.
So I wanted to show you this movie because this is a patient that does a lot of puzzles during the day. He's very cheerful, and this is his brain. So what you really see is the temporal atrophy, mostly oriented in the right temporal region, also left temporal region and orbitofrontal region. So just an illustration that FTD can occur in younger people and can be atypical. It's not always the sad story of a gray-haired person who is repeating himself all the time, not knowing where he or she is. This can be FTD. And another difference with the common dementia Alzheimer's disease is that in Alzheimer's disease, you see this diffuse atrophy with relative sparing of the primary motor and sensory cortexes, whereas in FTD, we still puzzle why there's only atrophy with a severe distinction between the more healthy parts of the brain and the more diseased parts of the brain in the frontotemporal areas. This is still a mystery because we can talk about proteins, we can talk about symptoms, but why is this only taking place here? It needs to be taken into account. So a little bit of history. Well, in the first place, FTD wasn't called FTD all the time. It was Pick's disease for a long time because it was described by Arnold Pick, who was a Czech psychiatrist, in a Prager medizinische Wochenschrift, where he described a woman, 72-year-old, with progressive aphasia, and he described the gross lobar temporal atrophy. Later investigated pathologically by Alois Alzheimer, who very honorably called it Pick's disease, because you saw the Pick bodies, which we now know is accumulation of tau. You could see this in argyrophilic stains. We still have Pick's disease, but it's now one of the complex of pathologies that you can find in a patient with frontotemporal dementia, which we pathologically call frontotemporal lobar degeneration. So then there were more, similarly in the 80s, there were two brain banks, the Lund and the Manchester brain banks, who found out that there were people who came to autopsy who did not have Alzheimer's disease, yet did have dementia, did not have Pick's disease, but had some type of lobar degeneration, frontal lobar degeneration, and they called it dementia lacking distinctive histologic features because they saw there was cell loss, a lot of cell loss actually, but they didn't know what it was. So they called it dementia lacking distinctive histologic pathology. Later, they found that there were stains that you could do, and then it were staining for ubiquitin, the ubiquitin protein. So they called it FTLD-U. And then it was in 2006, was relatively revolutionary. I still remember I was on the conference where this was announced. So that's 20 years from now, where they found that this ubiquitinated protein was TDP43. And this was the protein playing a role in the frontotemporal dementia patients that did not have tau pathology. Later on, we also found that there's another group, a smaller group, that not having tau pathology, not having TDP pathology, but having fused in sarcoma and other proteins, which we call FUS or FAT, depending on the proteins, how you rate them. So there needs to be a lot of progression in the pathology, because we have FTLD tau, FTLD TDP, FTLD UPS, and this continues to evolve, but the main groups are tau and TDP. But looking into the TDP, we've got now 4, or some people think 5 subtypes. So starting from a relatively simple disease description by Arnold Pick, just like Alzheimer's disease, we see that this is evolving and it's becoming more and more complex. And it's not the same as Alzheimer's disease, because for Alzheimer's disease, we still have got one pathology, which is made by 2 proteins, the amyloid beta and the tau protein. So, and if we look deeper into the types of TDP, you can see that it's in FTD, it's really dependent on where in the cortex, which layer you find, which morphology, and then also what do you find in the white matter. So type E was added by Eddie Lee, and so we've got, depending on if you see threads or other shapes, and where you see it all over the cortex or just in the first or 2 or 3 layers, then you describe it as type EB, etc. And this is still a matter of debate, because we really don't know if pathologists all over the world can easily classify this, and how large is the inter-rater difference. We still don't know that very well. But what we do know is that if you have a progranulin mutation, and here it's important to mention that there are 3 main mutations for FTD, causing FTD. The tau mutation, MAPT mutation, will give also tau pathology in the brain. And then the progranulin and C9orf mutation, they cause TDP type A in progranulin and type A and or type B in the C9orf mutation. So about 20 up to 30% of FTD is genetically autosomal dominant. So if you know that somebody is carrying progranulin gene, then you know that his or her pathology in the brain will be type A. And if you are carrying the C9orf repeat expansion, you will have type A or B and B in your brain. That's what we know. And then there's one other type, semantic dementia, which is the presentation of FTD starting in the left temporal pole, affecting semantic memory, mostly verbal semantic memory. If you have that clinical picture, you will have most likely TDP type C in your brain. But the landscape of clinical FTD is very, very broad. So there is the behavior variant, presenting with behavioral problems, the language problems, so non-fluent primary progressive aphasia, but also semantic dementia, with the problem in semantic memory. And then there's all kinds of motor problems with Parkinsonism, Huntington's disease-like, but also ALS. That's a very important overlap area, because about 15% of patients that do have ALS also develop FTD. And the same for FTD patients. There's a substantial proportion of them who develop ALS, much more than would be just by chance. And then there's also FTD with prominent psychotic symptoms. And there's even ALS with prominent psychotic symptoms. So everything is crossing, there are cross borders everywhere. And And then the question is, from this clinical spectrum, do we know the pathology? If somebody has a certain clinical phenotype, do we know the pathology? Well, actually, this is a rainbow. For FTD ALS, we know this is virtually always TDP43, and also for semantic variant, this is almost always TDP43 type C. But for example, if you look at the behavior variant FTD, this can be 50% tau and 50% TDP43. So not in every case that comes to the clinic, you know on beforehand what the pathology in the brain is. It's getting a little bit complex. So to diagnose FTD, what do we need? We first have to define the clinical phenotype. If somebody enters your room with behavioral change or with language problems or with psychosis or with a motor syndrome, you have to find out if this is neurodegenerative. Could also be functional neurological disorder or a primary psychiatric disorder. If you think it's FTD, it's neurodegenerative, you have to find out if it's genetic, because if it's genetic, you know the underlying pathology. That can be important for future treatment, but also you need to counsel the family. How can we define the underlying pathology? You need a biomarker for that. We also need to define the needs for care, so ultimately we can administer the right treatment. I think that's how it should look like, the landscape for the diagnosis of FTD. But what are the difficulties, the challenges in the diagnosis? The patients, due to the frontal lobe syndrome, doesn't complain. So if a patient comes to your clinic saying, I feel like I'm having much more trouble understanding social interactions, then that person will not have FTD, because the typical FTD patients, there's nothing going wrong. It's the spouse or the environment, they notice that there is something going on and they have to go to seek help from a doctor, and most likely that doctor, a GP, will say, well, if that person doesn't show up himself, I cannot judge it. So there's already diagnostic delay. There's a large variability in the presentation, as I showed you, but also in the disease duration. There are patients that live 30 years after symptom onset, which is much longer than Alzheimer's disease, but also some live much shorter, especially when they do have FTD with ALS. That can be 1 to 2 years. The age issue, which I'll come back to, and the non-memory issue. Because if you have a dementia, frontotemporal dementia, everybody thinks, when you think of dementia, think about memory and disorientation. But if you have completely different symptoms, which are much more complex to identify and to interpret, this can be a cause of diagnostic delay. And we also have the issue of how to measure. I will come back to that. That's just like several other diseases, frontotemporal dementia has phenocopies. So there are syndromes that look really just like FTD, but they are not. And one of them is the benign behavior variant FTD phenocopy syndrome, where people apparently do not have any neurodegenerative disorder at all. And it's mostly the spouse complaining about disinhibition, apathy, everything that's in the lines, as if they have read a book about FTD, but it's really not. How do we make the distinction? And at this moment, in contrast to, for example, Alzheimer's disease, we do not have reliable biomarkers for that, for all these questions. FTD is always considered a young onset dementia, and it's true that it takes a larger part of the pie when it comes to the distribution of causes of young onset dementia. Alzheimer's disease is still the most common dementia at younger age, below the age of 65, and FTD is a good second. But if you look at FTD, it can also present at the age of 80, for example. But the problem is when people are 75 plus, there will be no geriatrician thinking that a person could have FTD, because everyone after the age of 75, according to a geriatrician, will have Alzheimer's disease or mixed dementia. Because, of course, that's the most common dementia that they see. And they will never consider to do biomarkers because biomarkers are always positive in old patients. So it doesn't make any sense. So it's very hard to pick up the older FTD patients, especially also because if FTD patients are older, they more often have a memory presentation. So that looks like Alzheimer's disease. So you can only find out at postmortem that it's not Alzheimer's disease. So these are the international consensus criteria by Raskowski. You probably all know them. And in contrast to any other dementia, there's only out of 6 items, there's only 1 item describing something cognitive. And the rest is all describing behaviors. And these behaviors are sometimes very non-specific. Because if a person needs to have apathy, I think, well, we have a nursing home here. Probably 80% of all the patients who are here will have apathy. You know, it's so, what's its worth? And the same for disinhibition. I think if you go to this nursing home, many people will also have disinhibition. So it needs to be an early phenomenon, that's important, but still there's a wide range of disorders that also have these symptoms. So maybe it's uniquely describing FTD, but it's not very specific, actually. So we need more than that. Well, if you look a little bit more close, what clinical observations do we do in FTD? In general, they are very unconcerned about their symptoms. So they might have lost their job and they're just like childish, unconcerned. There's no sense of suffering. They have difficulty in perspective taking. They are not empathetic, and you can also find this out during the conversation. For example, when you have a conversation, you would like to have a dialogue, and the conversation with an FTD patient very often feels more like an interview. So you're asking a question and they say yes or no, or something very short, or they are telling their full story, and even if you interfere, they're not even noticing you. So the turn taking in the conversation is severely disturbed very often. And there's a lot of other things that you can notice. For example, even very subtle repetitive movements like doing these movements with the fingers, ticking, clapping, but also more complex stereotype behavior, which you will only notice when you see the patient next time. So when you have seen him, we'll give you a full story about his hobby, and see him next time, we'll give you exactly the same full story in the same words, which is very stereotyped. So all these things you can observe, but you can also see it sometimes in one eye. And this apathy, this disinhibition, this hyperorality, this lack of empathy, of course, shows a lot of overlap with primary psychiatric disorders. We've been working on it for a long time. Can we really differentiate these disorders? Well, on a clinical level, it is very difficult because it's very descriptive. You describe the symptoms. And for example, in major depressive disorder, you have a massive amount of apathy. And people who are depressed, especially at middle or older age, they will not complain about feeling sad. If you ask them, are you feeling depressed? Do you have a low mood? They will say, no. But actually they are depressed, but you can find it out by other features, like it's like they're losing contact with their emotions and their bodily sensations. Obsessive compulsive disorder, people who have stereotyped ritualistic behavior, the neuroscientific basis of that is different because they really have the urge to do that, while in FTD it's much more primitive. They do not have the urge, but they just can't inhibit the stereotype response. But there is a lot of overlap. Also with catatonia. In catatonia, people can be very perseverative. They can also have echolalia. well, that's actually very similar to frontal lobe syndrome. So you can be aware of nuanced differences, but at first sight, these symptoms look the same if you look at them cross-sectionally. Another challenge is the C9orf mutation. I don't know how much of them you see in Spain. It's in Southern Europe is apparently a little bit less, but in, for example, Finland, they have very, very many C9orf mutation carriers. In the Netherlands, we're a little bit in between, I think. But we've picked up quite a few of them without an apparent family history, just because we have this clinic where we have people entering that have change of behavior. Many of them did have psychiatric features, and we didn't think of C9orf at all, but by consistent testing, we picked up some of these cases carrying mutation. They can be very slow progressors. People often do not know when the first symptoms were there. Since adolescence, sometimes these carriers, not always, are a little bit more, different than other people without, you're not able to say they have autism spectrum disorder. They marry, they have children, but sometimes a little bit different in social contexts, but not so very obvious. And if you look at it, when in 2011 this mutation was described, they also found that it can, for example, present with a depression, bipolar disorder, or schizophrenia. And if you look at, this is a paper by Julie Snowden, she extensively described these patients that had psychotic presentations, and they have all kinds of psychotic phenomena, complaining of pieces of plastic emanating from his head, visions of the devil, monodelusion of weakness of the gluteal muscles. Now, you can read it. Man hiding in her garden, believed that his son was trying to kill him. So that looks like a whole psychiatry ward, but it is FTD. So those are the pitfalls. It can look like psychiatry, but it is neurodegenerative dementia. And then behavior variant FTD, the most often presenting feature, not always, is loss of empathy, loss of social cognition. And that is something that is very hard to find out that this is going on, and also very hard to measure. And for partners of patients, very hard to describe, because if you have a marriage with a person who has normal social cognition, and then very gradually that social cognition starts to decline. If you are the spouse, you are not going to say, I see that my husband has gradual decline of social cognition. When it's Alzheimer's disease, you can say, I observed that my husband is forgetting things more and more. But for this phenomenon, you end up with a marital therapist, because he's becoming rude, you think he will have an affair, or he will have burnout. Who, except maybe from 1% of the people who have a psychoanalytical education, will think of social cognition deficit? Nobody will interpret it like that. And that's why it doesn't enter our clinic at that stage. It doesn't enter our clinic at all. And what's also very important is that these parts of the brain who are involved are specifically affecting a certain cell type, the von Economo neurons, who are located here. And that's apparently where the disease starts. So we need to know a little bit more about these cells and about the biological phenomena taking place here. But yeah, it is very important that we can try to do something about it, because there is only one window of opportunity, and as the disease evolves, they're becoming more and more neuropsychiatric and also cognitive symptoms, and then there's physical, motor deterioration, and then if you have a diagnosis here or here, what can you do with therapy? So actually many caregivers say, yeah, that's even an ethical dilemma, because this is the first thing that changes, and this is the stage where people go to see a doctor. And actually here it happened already. They lost their personality. the personality that they had and that you were married with. So there are even spouses who say that if you develop a drug, yeah, it's of no sense. Because who are you going to treat? You are going to treat somebody else than the one you have been married with. And do you want this for a very prolonged stage? Yes or no? So that's very, very difficult. So that's why treatment in genetic cases is, of course, very important, why we need to study genetic FTD. And luckily, 20% of FTD is genetic. So then we can investigate the pre-morbid stages, and we can maybe even prevent frontotemporal dementia to occur. But if we talk about sporadic dementia, FTD, this is a very, very difficult thing. And we cannot just copy this from Alzheimer's disease, where people are very happy if they have lecanemab and they can have 3 months or 6 months of prolongation of their forgetful state, because they can still enjoy life in many respects. That's different. And how to measure empathy, that's another challenge, because you can do a lot of tests and there are multiple levels of social cognition. It starts from emotion recognition up to moral reasoning, and you can measure this in many, many ways. And this is all electronically. Look, you see that the behavior variant FTD patients, when experiencing the sad emotion in Ekman phases, only look at the eyes. They forget to look at the mouth. So that's already one way how it starts. They cannot really good see the emotions on the face. But that is not real life. That's a laboratory. And social cognition, that occurs in real life. And you need the examples. And you need to know how did the person function before. So, and it's not like a memory test where you can remember 3 out of 10 words or 7 out of 10 words. It's much more biased. It's difficult. However, even if we work with the Ekman phases test, we found that it can be an important clue to find out if somebody has the phenocopy syndrome, which is the not neurodegenerative FTD-like syndrome, and the real neurodegenerative FTD, and the same for depression-like symptoms. These two together made a relatively not really good distinction between FTD and the phenocopy. So it is clinically useful. And then another thing that is so amazing out of frontotemporal dementias is that people with semantic dementia, for example, this is how they envisage a cat, a bird, and a fish. Or this is the fish, the bird, and the cat. So you see that it's very perseverative, and they're going to lack specific features for the animals. So they have really loss of concepts. They don't know even what a strawberry is, but on the other hand, they can draw this. And they never get lost. How can you then make a diagnosis of dementia? Because people cannot understand that you can completely lose the concept of a strawberry, but you can do this. I'm so contradictory, so counterintuitively. And then we recently described with a large international working group the clinical appearance of the right temporal variant, which is actually like semantic dementia, but with the right temporal predominance. It's getting much more complex there because people have semantic knowledge less for non-verbal phenomena. So it can even be that they have a loss of knowledge for emotions or a loss of knowledge for sounds or bodily sensations. So when people come to see you and have all kinds of vague sensations, it's not because they have hypochondria, but it's just because they do not know anymore the normal things that happen when you have a bad throat or something like that. And they start to complain about heart beatings, not recognizing their emotions anymore. These patients very often end up to see a psychiatrist and are not being recognized as having right temporal FTD. Another thing that we found is that they quite often do have altered prioritization, with a hyper-focus on specific interests. And one of the examples, real-life examples that I met in my clinic was that a person really wanted to do some Sudoku puzzles, while his neighbor needed to be reanimated because of heart cessation and wanted to continue the Sudoku first and then go to save the neighbor's life. This is an example from our own clinic. I've seen her not in 2009 yet, but there it started. Looking at the case notes where she had already memory complaints, concentration loss and emotional instability. And I don't see anything wrong here on this scan. This is her MRI scan. Also not on hindsight. She had these attacks which were interpreted as epilepsy. And then 5 years later, she started to have hallucinations and anxiety. And still nothing really abnormal on her MRI. And we're thinking about a psychiatric disorder. And then 3 years after that, she was having loss of empathy, as a little bit more disinhibited. This is really like the Raskowski criteria for FTD. Normal Alzheimer's disease biomarkers, and then here she starts to have a little bit of medial temporal lobe and maybe also some more frontal dorsolateral atrophy. And there the question is this behavior variant FTD? We did a genetic screen and we identified an upturneuron mutation, which is one of the rare causative mutations of FTD. So that's confirmed. And then, so this is 15 years after 2009. She came to post-mortem. This is after death. And you see how the brain atrophy has severely evolved, severely. And these were her most recent symptoms. Extreme fear for water. We think this extreme fear for water or showering that you often see in FTD patients in nursing homes is also a phenomenon that you can attribute to the nonverbal semantic loss of the meaning of water on your skin, the meaning of a shower, which make it feel very unfamiliar, and that's why people are anxious about it, instead of not willing to have a shower. And then when we see the post-mortem, we see that there's once in a while, there's a TDP inclusion, and this is typed as type A by our neuropathologist. And this is very different from if you see at the same magnitude a tau staining in Alzheimer's disease. It's full of tau. In the same stain, there would be only 3 or 4 TDP stains. So that's a different magnitude here. And that, of course, have consequences for the biomarker development. So the lesson from this only one case, but it's just an example, is showing you that behavior variant FTD can have a very long prodromen, early stages, where you cannot really define what's going on, with normal neuroimaging in more than one early stage, with a high clinical overlap with psychiatric disorders. No reliable biomarker. There was no biomarker, only we could find this optoneurin mutation, but there's no else what we could do. And even if we would have a TDP biomarker, would it be helpful if there's so little TDP that you can find in the brain? So the pitfalls in biomarker development for FTD are these. We really do not have a good gold standard. Actually, the gold standard is the neuropathology, but we do not have anything else. We do not have a good gold standard because if you see frontal and temporal atrophy on the MRI, we don't know what the pathology is in the most cases. Another question is, how do these very focal and maybe very rare brain abnormalities translate to the CSF and the blood? If it's ubiquitous all over the cortex, all brain areas, you might expect that it's maybe more findable, detectable in the CSF and in the blood than when it's only here in the top of your head. How does it enter the CSF? We need to know about these processes. And then another question, are we looking at the right suspects? Because I don't, for the sake of time, I don't dig deep into the TDP metabolism, but it is quite interesting. I recommend you all to at least read the literature. It's so exciting. But TDP is just a protein, but it has a very regulatory function, and it's involved in maybe the transcription of about 600 genes. So are we looking at the right suspect if we're going to develop, with a lot of effort, a biomarker to measure TDP? Or do we have to measure something completely else? And another thing is, I think this is very, very important as well, is the assumption correct that if you have, for example, a genetic cause leading to TDP, let's say progranulin, that the metabolism of, or the biological pathways behind that are the same as TDP and sporadic FTD. Are the TDP cases the same genetically and sporadically? And are the tau cases comparable between tau, sporadic and genetic? Or could it even be that sporadic cases are more alike than genetic cases, although they have different proteins? These are just assumptions a lot of people base assumptions on these comparisons that have never been proven. And I think that's also very important to take into account. Then another thing that Aitana and I discussed also during lunch is that we always, even if we are a large research center, we may be very happy if we have 200 FTD cases. Well, that's not such a large number for a biomarker study. So, and we also need to validate it. So that's, of course, a call for collaboration, because we cannot do it as a single center. We cannot do single center studies here. And how do you validate it? Well, I'll give you some details on that, because if we start using biomarkers for FTD, and I'm now talking about fluid biomarkers, I don't do anything about imaging. First, we would like to know, is it FTD? The whole spectrum, which means it's not Alzheimer's disease, it's not psychiatry, it's not Lewy body dementia, but is it FTD? Luckily, for vascular dementia, we already have the MRI. Yeah? If you have the MRI, you see a high vascular burden. Okay, that's fine. For Lewy body, fortunately, we've got some measures too, but for Alzheimer's disease as well. But then we have to start looking, is it FTLD? And then, if yes, is it FTLD TDP43 or tau? I leave out of the consideration the more rare pathological phenotypes. And if it's FTD TDP, which subtype? And does it even matter? Does it even matter? We don't know yet. And then we have to take into account in which situation is this question relevant. Because we can go to look for FTLD TDP43 biomarker and apply this in FTD ALS and say, yeah, I can now identify FTD ALS using a TDP43 biomarker. If a biochemist is saying this, I as a clinician will say, yeah, we don't need a biomarker. I can do an EMG. So we really have to see, when is it relevant? When is there a question mark? And does the biomarker then answer this question? Is there a question behind the biomarker? And yeah, that's what I just wanted to illustrate from here. So if you have, for example, FTD ALS or semantic dementia, for these phenotypes, we really do not need a fluid biomarker. We need a biomarker for this one, and for this one maybe. So the first question, if it is FTLD, now we do have a good biomarker for that. It's good enough. It's the neurofilament light chain. If the question if it's FTLD or primary psychiatric disorder, and this can be different types of psychiatric disorders and different types of FTLD, there's always increased neurofilaments in the FTLD group. Note that there are also FTLD patients that are as low as the primary psychiatric disorders. So there's never a 100% distinction. But altogether, there's also a recent meta-analysis. They have a diagnostic accuracy around 85%. So to start with, if you have a patient with behavioral change and you don't know if it's FTD or primary psychiatric disorder, assuming that you've already ruled out the vascular pathology, the Alzheimer pathology, then a good starter is the neurofilament. What I also do in any case is offer genetic testing, because as we already heard, genetic testing can be useful even in case of a negative family history, and therefore can also be diagnostic. If you find a C9orf mutation in a patient with a psychosis, then you're already done. And then there are also studies taking into account the GFAP, but if you compare this with the meta-analysis on neurofilament, it's not really proven that GFAP has an additional value over neurofilament by itself. So I think you can just keep it to the neurofilament. But what is interesting, and this is just an example, I don't want to disqualify other research groups because we are doing this ourselves as well. But what you see here, they made a discovery cohort consisting of postmortem and genetically confirmed cases. They were not specifying which were postmortem and which were really question marks during life. And then they did a validation cohort in the PSP, of which we know this is a tauopathy, and the ALS, of which we know this is TDP. So that is what many people do. They take PSP, they take FTD, ALS, and they say, we found a biomarker. But what we actually need the biomarker for is if you have behavior variant FTD and you don't, and it's not genetic, and you don't know what is the underlying pathology. And that is, there we have very, very limited cases that do have pathology. And if you then do a single center study, I think you cannot claim that you find a good biomarker. But that's what we are all doing right now. Well, this is another example. This is the study by the group of Anja Schneider. I think the whole world, after this publication, sent their samples to Anja Schneider. Because then she would make the difference. Okay, is this tau or is it TDP? And I heard today that you're also trying to reproduce these findings. And I think many laboratories are. And unfortunately, there is no reproducibility, and it's very difficult probably also to do this in the lab. But also, if you have a very close look at their methods, also in their group, there's a very low number of pathologically verified cases that have a question mark during life, which is the pathology. Many of the validation cases are they already have a mutation, or for example, it's PSP, so you know already it's tau. So they have the same paradigm actually as all the other biomarker discoverers. And that's the same for us actually. So we had a study by Maddie Honey, and this is very counterintuitive because what we found was that AC tau, you would think, oh, this is going to identify tau. No, it was going to identify TDP43. Now, we don't know yet exactly how that comes, but never mind. If it's a biomarker, it's useful. And if you then have a closer look, that's also work by Maddie. You see that these are the pathology confirmed, and these are the pathology confirmed, and you see they're very, very rare in the whole group. Because most of the patients are semantic dementia, or having C9orf or progranulin mutations, or having FTD-ALS. So to be honest, in our sample, we also had very small numbers of pathology-confirmed cases. And if a semantic dementia patient comes to autopsy, it's still not the question mark that I'm looking for. So I think we need to be very, very critical on this. And the only way to escape this circular reasoning is to work together, put together all the pathologies that we have, isolate the cases that during life we could not know what the pathology was, and examine their CSF. So that's also a call for collaboration with our two teams. I think we could try to make an initiative here. So yeah, that's already the context I described. Go a little bit further, because, for example, if you look for FTD ALS, it's almost always TDP-43 pathology. Now, I already explained this. Other promising biomarkers. Well, some people, also in Amsterdam UMC, are now looking at the TDP-43 PET tracer. So far, it has not had great results yet. So very preliminary, I cannot say that it's very positive. But we are also looking at skin biomarkers, because there's a very interesting theory that the abnormal proteins, the abnormal aggregation of the neurodegenerative provoking proteins, does not start in the brain. Some people think it starts in the bowel, some people think it starts in the skin, or at least it may be outside the brain before it reaches the brain. And if you can find it in the skin, we still don't know if it's specific. So if you have, for example, alpha-synuclein in the skin, do you then always have alpha-synuclein in the brain? But at least it's a good way to see what type of pathology people have. And then there's also people now starting to look in the nasal mucosa. You can reach that by introducing a tube in the nose, going as far as the lamina cribrosa, and then wrap there and see if you can extract some nasal fluid. And these are some pathological slides staining with the TDP type A and B. Another interesting upcoming biomarker might be that we are going to look into the downstream effects of the TDP protein, which is the cryptic exon. You might have read about it, but what TDP-43 does, if you have a transcript from the DNA, it blocks parts of the DNA that do not need to be transcribed. If they are transcribed, it's going to be confusing because you will have products, peptides that are not functioning well. So you need to get rid of the cryptic exon. If TDP gets lost, the cryptic exons end up in the peptides or the proteins that are being formed. Some of them are being removed by a process that takes place in the cell, nonsense-mediated decay. So this is being removed. This is a healthy mechanism. It could also be that the protein is built as a building block. The cryptic peptide is in the building block of the protein. And then you need to identify it. If you find more proteins, including cryptic proteins or exons, then you might have a fluid biomarker. But it's very difficult to measure yet. We still have no ELISAs for this, for example. So at this moment, there's a large European consortium started, I think, over a year ago, Horizon 2020 project, where we all collect body fluids and all want to develop a more uniform way to have a staging for FTD and a diagnostic pathway for FTD. And I think one of the main reasons that we got granted for this project was because we wrote the recent discovery of Anja Snyder's group in it, which was very promising. So I think we were lucky that we could put that in the grant. So why FTD needs a different approach? To summarize a little bit, I mean a different approach from the common dementias, like, for example, Alzheimer's disease. Because 50% or more will not present in a memory clinic, but to psychiatrists, psychologists, etc., because of these different features. We do not have common words for their features, so we need to find out how we identify it, how we interpret it. Another reason is that there's the very high impact of genetic FTD. So that needs another approach. We need it for the proper patient care, but also very important for research of biological mechanisms. Because of the late diagnosis, there's often very severe societal impact. For example, people have lost their jobs, have already gone through a divorce, or have lost contact with their children who never want to see them anymore after they've insulted severely their girlfriend. It's a challenge because if there is treatment, it needs to address multiple protein pathologies. So we cannot have one treatment fits all in FTD. That's very unlikely. And that's why we need a very good biomarker development program. And there are ethical questions regarding treatment because the window of opportunity is actually very small. So we need societal awareness, pathology-specific biomarkers, clinically relevant outcome measures. Actually, I think it's very important that we take into account psychiatry and psychiatric expertise in the care for people with frontotemporal dementia, not only neurological. We need a better understanding of pathophysiological processes. And because of TDP, with so much commonalities with ALS, we are now aligning much more with the ALS field. Formerly, we aligned very much with the Alzheimer's disease field, but now we're really aligning with the ALS field. And I think that's very important because these guys are already developing a lot of therapies, curative therapies for ALS. And that's it. Thank you. This is my group, the large group of the Alzheimer's Center, and the smaller group where we do this translational research from bench to bedside in FTD.
Okay, thank you so much, Yolande. Questions for her?
So thank you very much for this very interesting presentation. I admit I know very little about frontotemporal dementia, but bringing it closer to my expertise, there is one neurophysiological biomarker that is, at least in the differentiation between Lewy body dementia, Alzheimer, and frontotemporal dementia, is pretty specific for frontotemporal dementia, which is a loss of long interval cortical inhibition, which is a pretty nice biomarker because many of these measures are very variable, and that one is not. It's very is a very strong inhibition in normal people. So I don't know if that can enter into a useful question moment type of situation, and I do not know the neuropsychiatric part. So if it's altered in that differential type of diagnosis, but just to putting on the of course it's not scalable like a fluid biomarker. Of course, you need to have the person in the lab for a certain period of time to do the measurement, but it is I don't know, just to putting on the
once again,
it's long interval cortical inhibition.
Okay.
It's a pair pulse protocol.
Okay.
And we do that here, so it's one of the things that we are already doing in.
Can you read it from the normal resting EEG, or do you have to?
No, it's TMS from motor cortex. So you need just a TMS coil and EMG amplifiers.
Okay.
So it's a loss of cortical excitability. So inhibitory GABA B inhibitory circuits in motor cortex.
That's new to me. I would take it into account. Thanks
so just to and there is the literature is done by, it's a pretty solid literature because a lot of these neurophysiological studies are normally done with small sample, and this is kind of big sample type of literature from an Italian group that work pretty nicely. So it's just to putting on the map.
Thank you. Yeah, might be very useful.
Any other questions? I can ask you. Well, I have many questions, but one of the questions that I've been asking myself in the past few years working in FTD is: are we putting the focus on the for fluid biomarkers? Should we move away from looking for biomarkers specific of underlying pathologies? Because my sense is that first, there is no, as you said before, there is no correlation between genetic FTD and sporadic FTD. What we find in genetic FTD, then we can apply it. And we really still don't have a specific biomarker. right? So even though the cryptic exons or TDP43, nothing, and the tau biomarkers that we have, they are not useful for FTD. So
Yeah.
what are your thoughts on
Yeah,
that?
I agree. Actually, I think since TDP43 has been found, when was it? In 2006. So that's 20 years ago. So for 20 years now, the whole world has been looking for distinctive biomarkers for either tau or TDP, and we didn't find it. So I think we're not looking at it in the right way. Yeah, I completely agree actually, but I find it very hard to know what then do we have to look. I mean, we have no alternative, so we keep looking at the Holy Grail, but yeah, I think it's too good to be true that if you now, after 20 years of intensive research, say, hey, I found this one biomarker that can distinguish. Now, even this AC tau, it's my own group. I belong to this group, but I think I don't know if we're really going to use this in clinical practice like that.
Yeah, because also
Yeah.
from the broad proteomic
Yeah.
studies,
Yeah.
it's so variable depending on the cohort that
Yeah.
you look at,
Yeah.
the technique. Because I was also thinking maybe we are with this kind of like wide proteomics, untargeted.
Yeah.
I mean, with the targeted, we are missing candidates, but with the untargeted, we might miss very low abundant proteins. But then, what is the applicability of that? So there's still no any hints or any light at the end of the tunnel for this. So
What makes it very difficult also is that I think, for example, Alzheimer's disease affects virtually the whole brain, and everything ends up somewhere in the CSF. But in FTD, you have specifically frontal, specifically temporal. Already those cells located there are different. So the metabolites might be different. And if we just make FTD one group, we cannot identify the subtle and I think you're right, like the non-frequent candidates are not being found like that. Just for example, if you do genetic screening in autism, it's very difficult to find rare variants that have high penetrance, because if you do this large group, you will never pick it up in the GWAS or something. So I think it's a little bit similar for FTD. It's too heterogeneous to make serious business in finding one thing. Yeah, we need to be creative. And yeah, I think I very much believe in pathology, although the drawback there is, of course, that we are a little bit late in the process. So there's a lot of things that happened are not visible anymore because they are simply not there anymore. If you hear Eddie Lee talking about why there's so little TDP in the brain, he thinks that it's just gone. And yeah, it was there, but we look through the microscope, we don't see it anymore. So yeah, that's the brain, it's in the skill, and we cannot look in it 20 years before somebody dies, Yeah. So if somebody has a creative idea, yeah. But I think the most important message I also wanted to give you is to be critical. Because I don't know the answers, but I think you don't have to swallow everything that people are publishing. And we know this. Everyone tries to make a good publication, but I think in some respects we are still very far from solutions in FTD. Yeah.
Yeah. Thank you again for your speech. But I have not the answer for this. But I have another perplexity with when considering the whole group of. So for me, to talk about frontotemporal dementia, clinical frontotemporal dementia is really heterogeneous. That is really heterogeneous. You can find classifications where you can find tauopathies, Parkinsonism, and that is. For me, it's very strange. But then, you have shown the criteria, the pathological criteria. So we talk about frontotemporal lobar degeneration. So we limit. That is the real group where we pathologists talk about frontotemporal dementia. That is frontotemporal lobar degeneration, which is TDP, yeah, with ALS or not, PIC, and genetic tau frontotemporal dementia, but not PSP, cortical basal degeneration.
No.
That is, again, noise
Yeah,
for biomarker.
I agree. Yeah.
And there is another, to put things even more complex, I am sure, I mean, that is not that I believe, I mean, it is true that for every neurodegenerative pathology group based on molecular features, you find frontotemporal degeneration cases. So frontotemporal dementia mimics. We talked about prion diseases, but synuclein, multiple system atrophy, you have frontotemporal, and in Lewy body disease also, in PSP also. So I wonder always that I think about frontotemporal lobar degeneration. I mean, I would look at the group from a, so to say, macroscopic point of view, because they are all Alzheimer's, frontal Alzheimer's variants. They look all very much the same, and the clinic also. So I was just, when listening to you, wondering if, from a biomarker's point of view, all these different entities could have something in common. GFAP, or something in common, and then we could differentiate each molecular group. Of course, the main ones are TDP, and tau. Why not? But well, that could be one approach.
Yeah. Thank you for the comment, sir.
Hi, thank you for the talk. I was wondering, I would like to know your opinion if you have seen the studies in which they are measuring the translocation of TDP-43 from the nuclei to the cytoplasm in lymphocytes. And what do you think? Because for TDP-43, I agree that it has been very difficult to find a marker, but maybe we were looking at trying to find the whole amount, like I guess we do with tau, to quantify it, but maybe we should focus on where it is located, and if we see this depletion from the nuclei, that we can actually account for more biomarking than actual numbers of amount of TDP-43. So I was wondering your opinion about the lymphocyte. Also, lymphocytes are external, cells from the CNS. So I don't know. I would like to know your opinion.
I don't know if you have enough knowledge yet that if you find this in lymphocytes, that it really means you also have this pathology in the brain. That's the difficulty, I think. We really would need to know that. Otherwise, if you find translocation from the nucleus to the cytoplasm in lymphocytes in somebody who is depressed, so that's the
numbers,
the chicken and the egg is different. You need the chicken and the egg. Yeah. That's for all the peripheral biomarkers, the question. You can do a peripheral biomarker, but you need to know in the same time what is going on in the head. If you don't know that for large groups, then it's a little bit dangerous. Because imagine that there is more peripheral pathology than central in the brain pathology, then you would make false positive diagnosis. Yeah.
Thanks.
Yeah.
And I have two small questions. One pathological and the other physiopathological. The pathological one is related to the cells that you pointed out at the beginning of the talk, the bone economous cells.
Yeah.
Is there any specificity in any form of the FTD for this type of cells? There are any other conditions where they are also involved?
Yeah. That's true. So the idea, and that's mostly raised by Bill Seeley from UCSF, is that von Economer neurons are specifically involved in FTD. If you do cell counts, they degenerate more relatively than other cells in that same region. And we know from cell counts that these numbers are also lower, maybe congenitally or around adolescence in people with autism and schizophrenia. Yeah.
The physiopathological question is it's a contrast with Alzheimer's disease. In Alzheimer's disease, we have the amyloid cascade hypothesis. It's very criticized, but it's a main hypothesis that defines the condition. Is there any similar or parallel hypothesis for frontotemporal dementia?
As far as I know, there's no cascade hypothesis.
We have
No.
no,
And there's also no
any
Braak's.
physiopathological model.
No. No, I know Braak staging as well. It's no, that's not available for FTD. And I don't know if it's there. I don't know. Yeah. Yeah. What we do know, of course, is and more is that there's a lot of co-pathology, yeah, in all the dementias. Also in young onset dementia, so not only old people. And for example, in people with Alzheimer's disease, there's about 60% of them having TDP as well, inclusions, and a lot of people with 2 or 3 co-pathologies have also a faster decline. So the pathologies are not just epiphenomena. But yeah, if you really look at these libraries describing protein networks, there's a lot of overlap between the tau and the amyloid and the TDP, and so they're not all by themselves. Yeah.
Any more questions? No? Well, so thank you so much, Yolande, again.